Welcome to the 8th video in our ECG series. Now that you understand ECG basics, let's explore how to identify arrhythmias on an ECG strip and their respective treatments. Arrhythmias are deviations from the normal heart rhythm. They are true medical emergencies, as many of them allow only a few seconds before a patient collapses. Let's go through each one, how to recognize it on an ECG, and its treatment. Arrhythmias are classified into two main types: supraventricular arrhythmias and ventricular arrhythmias. Supraventricular arrhythmias. Supraventricular arrhythmias originate above the ventricles, typically in the atria or the atrioventricular AV node. They include sinus tachycardia, sinus bradycardia, atrial fibrillation, atrial flutter, and supraventricular tachycardia, SVT. Sinus tachycardia. Sinus tachycardia is a condition where the heart rate exceeds 100 beats per minute while maintaining a normal rhythm. The ECG shows normal P waves preceding each QRS complex with a shortened RR interval. When the heart rate exceeds 250 beats per minute, sinus tachycardia is classified as supraventricular tachycardia, SVT. Causes include fever, dehydration, anxiety, hyperthyroidism, or stimulant use. Treatment involves addressing the underlying cause, and beta blockers may be considered in symptomatic cases. Sinus bradycardia. Sinus bradycardia is characterized by a heart rate below 60 beats per minute with a regular rhythm. The ECG reveals a prolonged RR interval while maintaining normal P-wave morphology. It is commonly observed in athletes, during sleep, or as a result of medications such as beta blockers. If symptomatic, treatment includes atropine administration, and in severe cases, a pacemaker may be required. Atrial fibrillation, AFib. Atrial fibrillation is an irregular rhythm with absent P waves and variable RR intervals. The ECG displays fibrillatory waves instead of distinct P waves. It increases the risk of stroke due to the formation of atrial thrombi. Management includes rate control with beta blockers or calcium channel blockers, rhythm control with antiarrhythmic drugs, and anticoagulation therapy to prevent thromboembolic events. Atrial flutter. Atrial flutter is identified by a rapid atrial rate, typically around 300 beats per minute, with a characteristic sawtooth pattern of flutter waves on the ECG. The ventricular response may be regular or irregular, depending on the conduction ratio. Treatment includes rate control with beta blockers or calcium channel blockers, and catheter ablation is often recommended for long-term management. Supraventricular tachycardia, SVT. Supraventricular tachycardia is a narrow QRS complex tachycardia with a rapid, regular rhythm, often without visible P waves due to their embedding within the preceding T waves. It is typically caused by re-entrant circuits involving the AV node. Treatment includes vagal maneuvers, adenosine administration, and catheter ablation. Now let's explore ventricular arrhythmias, another critical group of heart rhythm disturbances that originate in the ventricles. These arrhythmias can be life-threatening, and it's crucial to recognize them on an ECG in order to act quickly. Ventricular arrhythmias include ventricular tachycardia, VTach, ventricular fibrillation, VFib, ventricular flutter, and torsade de pointe. Let's go over each one, how to identify them on an ECG, and their respective treatments. Ventricular tachycardia. Ventricular tachycardia is a rapid heart rhythm originating from the ventricles, typically defined as 3 or more consecutive premature ventricular contractions, PVCs, at a rate greater than 100 beats per minute. On the ECG, you'll see wide QRS complexes with no identifiable P waves, and the rhythm is regular. The heart rate in VTach ranges from 100 to 250 beats per minute. VTach can be sustained, lasting more than 30 seconds, or non-sustained, and it can cause symptoms ranging from dizziness to cardiac arrest if untreated. Causes include ischemic heart disease, electrolyte imbalances, cardiomyopathy, and drug toxicity. Treatment: stable VTach. Antiarrhythmic drugs like amiodarone or lidocaine may be used. Unstable VTach. Immediate synchronized cardioversion is required. Recurrent or sustained VTAC. An implantable cardioverter defibrillator, ICD, may be needed for long-term management. Ventricular fibrillation. Ventricular fibrillation is the most critical of the ventricular arrhythmias. The ECG shows a completely erratic, chaotic baseline with no recognizable QRS complexes, P waves or T waves. This results in the ventricles quivering rather than contracting effectively, causing a complete lack of blood flow and leading to cardiac arrest. Treatment for VFib is urgent. Immediate defibrillation. The first-line treatment for VFib. CPR. Begin chest compressions immediately until defibrillation is available. Post-resuscitation care. This may include medications, targeted temperature management, and identifying the underlying cause of the VFib. Ventricular flutter. Ventricular flutter is a rapid, regular rhythm with wide sinusoidal waves on the ECG. The heart rate typically ranges between 200 and 300 beats per minute. It is highly unstable and often degenerates into ventricular fibrillation. Treatment: immediate defibrillation, essential for stabilizing the rhythm. Antiarrhythmic drugs like amiodarone can be used to help stabilize the heart. Torsade de pointe. Torsade de pointe is a form of polymorphic ventricular tachycardia, often associated with a prolonged QT interval. The ECG shows a characteristic twisting pattern with QRS complexes that appear to rotate around the baseline. This arrhythmia is linked to conditions that cause a prolonged QT interval, such as electrolyte imbalances, especially low potassium or magnesium, certain medications, or congenital long QT syndrome. Treatment: magnesium sulfate, the first-line treatment to stabilize the rhythm. Correct electrolyte imbalances, particularly potassium and magnesium. If the patient is unstable, immediate defibrillation may be required. Temporary pacing. In some cases, pacing can help shorten the QT interval and prevent recurrence. Conclusion: ventricular arrhythmias are among the most dangerous heart rhythm disturbances and can rapidly progress to cardiac arrest. Recognizing these arrhythmias on an ECG and providing immediate treatment is critical to saving lives. If you encounter any of these patterns, always correlate with clinical symptoms and take quick action. Stay tuned for more insights on ECG interpretation. Keep learning, and remember, timely intervention is key to keeping the heart in rhythm.